So this is I'm generally approaching these final sort of tidbits of transplant as other complications and of transplantation and non-renal transplantation. Okay, so what are some of the other complications in kidney transplantation we have to talk about? They're the metabolic complications of transplant. So of course, dyslipidemia is a big one. Dyslipidemia is extremely common. There is a variety of causal factors. The steroids, the calcineurin inhibitor we talked about raises lipid levels. mTOR inhibitors, we talked about how that can massively elevate triglyceride levels, even to ranges that you worry about pancreatitis. Again, cyclosporin and RAPA have higher rates of dyslipidemia or severe dyslipidemia when compared to tacrolimus. And this is not insignificant because, most of our patients with transplant are dying of cardiovascular disease. So we pay attention to dyslipidemia. Statins are the first line. There is a randomized controlled trial looking at fluvastatin, if I remember correctly. It's either Prava, I believe it's fluvastatin. There's a randomized control trial in transplantation looking at the early initiation of fluvastatin on transplant patients, irregardless of their lipid levels. And there was a reduction in cardiovascular events, but no change in mortality or graft survival. Okay, but there was a statistically significant reduction in cardiovascular events. We talked about some of the drug interactions when we were discussing calcineurin inhibitors. Remember, cyclosporin increases all statin levels because cyclosporin not only has influence on CYP3A4 activity, but also this P-glycoprotein and organic anion transport processes that metabolize and clear statins. So in general, cyclosporin will increase all statin levels. If you want to reduce the interaction, you can choose statins that are not metabolized by the CYP3A4 system. The ones that are most commonly used are Crestor, rosuvastatin. Pravastatin is much less potent than Crestor. Pitavastatin is a more potent, most potent statin, but is not in common use. But remember again, still there will be an interaction with cyclosporin through P-glycoprotein or organic anion transport processes. Okay. The effect of tacrolimus on statins is less. I think I mentioned this, when I was a fellow, we did reduce the maximal dose of atorvastatin when combined with tacrolimus. We decreased the dose by roughly half, but it appears you don't have to do that when looking more rigorously at pharmacology data. The interaction with tacrolimus is much less. Okay, fibrates are sometimes used in the transplant patient when triglycerides are especially high. There is an effect of fibrates on creatinine, particularly fenofibrate. Okay, it can increase creatinine without necessarily dropping your GFR. Remember, when you're using fibrates and statins together, there's an increased risk of things like rhabdo and hepatotoxicity. So as long as you're not having rhabdo, the increase in creatinine with fibrates may not be a drop in GFR, but may be related to changes in creatinine kinetics. Gemfibrozil has less risk of this change in serum creatinine, but it has more risk when combined with statins for the myopathy and hepatotoxicity. Okay. Moving on to another major cause of metabolic derangement in your transplant patients, and that is diabetes. um, uh, especially new onset diabetes. As an aside, there certainly are patients who have diabetes as a cause of ESRD or contributor at least. They go on to dialysis, their diabetes remits because of impairments in insulin clearance as you develop profound renal failure. And then you give them a kidney, and then now they're back on insulin and steroids, and their sugars are all out of whack. So that aside, right? The relapse, let's call it, if I can use that term, of diabetes post-transplant. This is new onset diabetes. So in general, the incidence of new onset diabetes after transplant is decreasing. Used to be roughly a third of patients had new onset diabetes. Now, recent analysis would say in long-term patients, that risk is maybe only 10%. Why are we having less new onset diabetes? Probably because we're using less steroids. So there are more centers that are doing steroid-free protocols. There also is now belatacept as a calcineurin inhibitor sparing therapy. And then, we're probably doing more induction and less and lower CNI levels. And that would also be an explanation. Okay. So risk factors for NODAT include Hispanic patients in particular, Blacks as well, some of the obvious ones like family history, high BMIs. This is less obvious. Hep C infection is a pretty potent risk factor for NODAT. Why is that exactly? It's not, the physiology is not well spelt out, but it's clear and prominent signal. So chronic hep C infection, it remains to be seen whether this is still a major factor now that we have very effective anti-hep C therapies. I would assume it's less, okay? But still probably not back to baseline, okay? Greater HLA mismatches are presumably managed with more steroids and higher CNI levels. We talked about calcineurin inhibitors as causing insulin resistance. Tacro and Rapa cause more NODAT than cyclosporin. Magnesium deficiency is a very interesting risk factor for NODAT, okay? And so some would also describe the diabetes that occurs with thiazide diuretics as a problem with magnesium homeostasis. So how does magnesium deficiency cause a predisposition to diabetes? Seems to work both afferent and efferent, that is on insulin release as well as insulin sensitivity. People have shown, direct effects on the islet cell and effects on sulfonylurea receptor in increasing insulin release when you decrease intracellular magnesium content of a insulin secreting cell. And there may also be some increases in or decreased insulin sensitivity, but it's clearly a risk factor. So that tells you that you should be following magnesium in your transplant clinic and not just sort of saying, your magnesium's not too high. We'll just kind of monitor it. If you want your patient not to get diabetes, you should take that seriously. Certainly, diabetes post-transplant does seem to affect allograft survival and patient survival. Moving on, we'll talk about post-transplant erythrocytosis. This is something that might happen in as many as a quarter of patients. It usually happens early on. Risk factors for this include presence of native kidneys that are patients that have not undergone native nephrectomy. Okay, those patients would have less risk of post-transplant erythrocytosis, which of course is most patients. Male patients, higher baseline hemoglobins. PKD generally has higher hemoglobin concentrations. Maybe that's because PKD patients are generally healthier and have less anemia of chronic disease, but also it seems that PKD patients and the architectural distortion that occurs with PKD seems to cause areas of low oxygen delivery in parts of the kidney that would expectedly increase EPO secretion from some of these interstitial cells in the kidney, right? So, the reason why your OSA patients get polycythemia is that there's low oxygen delivery to EPO secreting cells, including the main source of EPO, that is the interstitial cells in the kidney. Okay, so PKD may be this state of architectural distortion where you have areas of hypoperfused kidney interstitial cells, and therefore an increase in EPO. Interestingly, diabetes, smoking, just like in your secondary polycythemia, may have risk factors. One other thing to add to this, which I only recently learned, actually Andrew brought this up, and showed me this data. SGLT2 inhibitors should be added to this. For those of you who don't know, polycythemia is a known complication to SGLT2 inhibitors, and there's a hypothesis about why that occurs, but that is not esoteric. People have shown clear signals of increases in hemoglobin after starting EPO. Okay, and polycythemia is a known complication. Sorry, I said EPO, I meant SGLT2 inhibitors. Okay, pathogenesis of this post-transplant erythrocytosis is not clearly described, but this is not it is a state in which EPO levels are higher than one would expect. Now, angiotensin participates in the regulation of EPO response, okay? And so you can leverage this by treating with angiotensin receptor blockade or ACE inhibitors to reduce the response to this higher EPO level. So our first-line treatment for post-transplant erythrocytosis is to retard the response to these, inappropriately high EPO levels with ACE inhibitors or ARB. If that's insufficient, then we send these patients over to hematology for consideration of intermittent phlebotomy. I would say that we're not often using theophylline these days. Okay. Moving on to infection, which is a big topic in transplantation. If there are no questions about these metabolic derangements. Well, it would be presumably a little of both, right? Because the fact that the PKD patients are at higher risk of this, it suggests that they already have native EPO production, native kidney EPO production, and then they didn't have erythrocytosis until you added another kidney to the mix, or you decreased the chronic phlebotomy that happens. I guess you could think of that as well. Remember, maintenance dialysis patients are somewhat protected against erythrocytosis because every time they get dialyzed, there's a little bit of blood left over in the dialyzer, right? And so if you stop that, then you are, that may be another unmasking of a predisposition to erythrocytosis. But even dialysis patients with PKD have higher hemoglobins and lower EPO requirements than non-PKD dialysis patients. If I understand the question, we're saying if the donor came from an HCV positive donor, does that give an increased risk to the recipient? I would say no, right? There's a lot baked into that question because in the past, we would not donate HC positive kidneys into HCV negative recipients, but now we do. because we have effective antivirals. So as long as you're, again, addressing the viremia, you should mitigate the effects of diabetes, right? So a donor kidney with hep C that caused transient viremia, but you treated it right away, I would predict, doesn't cause post-transplant diabetes mellitus. All right, so moving on to infection, which is a big topic. We'll conquer BK quickly. I think quickly, maybe not so quickly. So a couple of things to know. BK virus in renal transplant, the bad virus seems to come from the allograft, okay? So people have sequenced the BK from renal transplant patients, and they found that that BK seems to be of donor origin, okay? And because of that, there's a different phenotype than what you see in non-renal transplant patients, okay? You can get BK reactivation in non-renal transplant. The most common scenario in which you see that is in BMT patients, heavily immunosuppressed. When they reactivate, they don't typically get CKD or rising creatinine, they get hemorrhagic cystitis. That's the manifestation of a BMT patient who reactivates their BK. That BK was of native origin. That's my BK that's been latent in my body, and then reactivates. But it's rare, though not impossible, for non-renal transplants to get BK reactivation in the kidney that causes interstitial nephritis. That's the end result, okay? It's basically an interstitial nephritis in response to viral replication in the kidney, okay? You can see it though, okay? I've seen a heart transplant patient who developed rising creatinine, biopsy reveals BK in the kidney with interstitial nephritis, but that's not common. Why does it happen more commonly in less immunosuppressed patients, right? Renal transplant patients are less immunosuppressed than BMT patients and heart transplant patients and lung transplant patients, but they get BK nephropathy. Again, it's because that donor kidney with donor BK that's quiescent in that allograft is more likely to escape the recipient preformed antibodies to BK and preformed T cell response to native BK or recipient origin BK, right? You're giving them a novel coronavirus. You're giving them a novel BK, right, with the organ. BK resides in transitional epithelia, okay? And so you're giving them new transitional epithelia, harborizing a novel BK, all right? Most of us have BK in our transitional epithelium, okay? This point I've already said. I've already said this. And then there's a less common form of polyomavirus nephropathy, which is JC. And then you can even get non-polyomavirus interstitial nephritis, things like adenovirus, which are less common. We're focusing on BK because far and away that's the most common viral interstitial nephritis that you're going to see. Okay? How do these patients present? Well, sometimes with hematuria. Rarely we're going to see cystitis. Remember, again, that's in the BMT patient, the hemorrhagic cystitis. There's a correlation with ureteral stenosis. I think it's probably a very unlikely, cause of ureteral stenosis, but rather is a surgical rationalization. Oh, that ureteral stenosis was not surgical technique. That was the BK. Okay. All right. Interstitial nephritis is the one that we worry about the most. Okay. And when we use the term BK nephropathy, we're referring to that interstitial nephritis. Okay. How does this present? Well, allograft dysfunction. Rarely I'm getting systemic symptoms, but I can. And then I often will have pyuria, okay, and hematuria sometimes. Now, BK viremia seems to always precede the development of nephropathy, okay? Viuria, shedding a virus in my urine, precedes viremia, okay? So, as it goes, if you're monitoring your patient, they first have virus in the urine, so viuria, and then viremia, okay? And then only can you get BK nephropathy, okay? And there's a threshold at which the risk of BK nephropathy seems to be real. When viremia exceeds 10,000 on this PCR study, that's when this risk of BK nephropathy starts to be meaningful, such that most centers don't bother with measuring BK viuria. That's too early a signal. And if you start pulling back on immunosuppression just for viuria, you may risk rejection. So most centers track BK viremia in order to ensure low risk of BK nephropathy, okay? Because that seems to precede nephropathy. The risk of BK nephropathy, it's not rare. Okay, it happens in 1 out of 20 patients. It usually happens within the first year, okay, most of the time within the first few months, which means that you shouldn't have to be monitoring BK PCRs as routine monitoring in post-transplant patients after the first year. Okay, if you don't have allograft dysfunction, don't be sending BK PCRs after the first year. Now, somebody just got treated for rejection, you kind of reset the clock, right? You can start checking BKs again. If you're 2 years into it, you got a rejection treatment, you might want to check BKs again. But if somebody's not had a rejection, you don't need to check BKs after the first year, okay? How do we diagnose BK nephropathy? Again, we really rely on BK PCRs, but for historical significance, and because this can show up on a board exam, there's something called a decoy cell that you can see sometimes present. A decoy cell refers to this mimicking of these abnormal, morphologically abnormal tubular epithelial cells, or sometimes transitional epithelial cells, or more often even transitional epithelial cells that mimic transitional cell carcinoma, okay? When BK virus replicates in these epithelia, it creates an angry looking cell. Often the nucleus is really large. You have this high nucleus to cytoplasm ratio. That is something that you typically see in rapidly dividing cells like cancer cells. Okay, so decoy refers to these cells that look like cancer cells. It shed into the urine. Okay, you can sometimes see intranuclear inclusions that are these conglomerates of viral replication. Okay, this has some reasonable specificity, but nobody does this anymore. Okay, it can show up on a board exam though. Most of the time, again, BK PCR, you can see, is a highly sensitive test, right? Captures 100% of BK nephropathy. Specificity is less because it anticipates BK nephropathy, right? You can have viremia without nephropathy, right? Renal biopsy is going to be done to make the diagnosis. It is said that BK replication happens more in the medulla, which makes sense as you think about where BK lies latent. Remember, it's in transitional epithelium. Embryologically, your collecting ducts are coming from some of the primordia that is making your ureter and bladder. Okay, it's the connection of the mesonephros with these ureteral buds that form the collecting duct. Okay. Some people appreciate those medical school days where that guy or gal was trying to beat that into you. One day this will be important to you. You probably said, nah, probably not. But here they come for their revenge. BK nephropathy in the deep medulla. Okay. But that being said, I would say most of us don't say, okay, you're looking for a BK, I'm going to biopsy you extra deep, right? Because of the risk of bleeding, right? Okay. What do we see on biopsy? We see basic tubular injury, right? This is tubular cell dropout, or cells that are being shed, tubular injury. Flattening tubular epithelium is just another signal of tubular injury. And then again, sometimes I can see these viral inclusions in the nucleus. You can see them on light microscopy as this little pale spot in the nucleus sometimes, and then you can see them on EM especially well, okay? But again, it's an interstitial nephritis, so you see a lot of recruitment of inflammatory cells. You can see tubulitis. What is tubulitis? Remember, that's when these compact nuclei are traversing the basement membrane of the tubule, right? Remember, that's a lymphocyte in contrast to this tubular epithelial cell. Okay, if I have BK nephropathy, I'm going to have an even larger cell, a cell that's larger than that, a nucleus, I should say, nucleus that's larger than that tubular epithelial cell nucleus. And then again, it might have this intranuclear inclusion that I can even see on light microscopy. Okay, that would be the appearance of a BK infected epithelial cell. I rely on a special stain called the simian virus 40 stain. There's just a there's sufficient similarity between BK polyoma virus and this other simian virus, such that an antibody directed to SV40 also binds BK antigens. Okay. And that's not a routine stain. You ask for, SV40 staining, or the pathologist recognizes that, yeah, this looks abnormal and I'm worried about BK. So they'll do the stain. Okay, what's the prevention of BK nephropathy? It's based on detecting PCRs. Often we're doing monthly PCRs in the first 3 months, and then, some less frequent checks after that. Each center has their own protocol. Okay. When viremia is detected, we generally reduce immunosuppression in some way. Traditionally, centers will often use the antimetabolite as their first modification, right? They'll either drop the antimetabolite, drop the dose of the antimetabolite, or even stop the antimetabolite. But that's not, if you have somebody who's having some side effect to their CNI, right? Neurotoxicity, for instance, they can't tolerate, or GI upset from the macrolide FK. Remember, it's not just mycophenolate that can cause GI upset. We went over that, right? FK is a macrolide. It can stimulate motilin, cause diarrhea. You might say, well, instead of decreasing the antimetabolite in you because you're having all this tremor, I'm going to decrease your FK levels, right? That could be considered. You're just trying to reduce the sum total of their immunosuppression. Okay, treatment of BK. If you develop BK, it's not great. We don't have a lot of great options. In general, it's just lower immunosuppression in a bigger way. Okay. And then we're checking BK PCRs. We're looking for reduced viral replication, as well as that drop in serum creatinine. And then if you're not responding to reduction in immunosuppression, we're really starting to throw Hail Marys. Okay, there's no good evidence-based intervention. IVIG is considered, especially if you have low immunoglobulin levels. Cidofovir is a nephrotoxin, but might have some antiviral effect. Okay. Leflunomide, I talked about in our discussion on immunosuppression, is an old intervention that was tried back in the day. It is it's an immunosuppressant, and in vitro might have some antiviral effect, but nobody's really shown good data that reveals a positive effect of that drug. Okay. Questions about BK before we at least do a little preliminary? Maybe I'm going to come back to CMV so I could do that in a chunk. Let's kind of knock off some of these shorter ones. The CMV is big enough to sort of spend more time on that. Okay, let's do a few quick ones. PJV, pneumonia is something that we try and prevent with prophylaxis. Each center has their duration of prophylaxis that they prefer. It's usually somewhere between 6 to 12 months. Bactrim is our usual go-to. Remember, it has anti toxo effect. The sulfa portion of the Bactrim has anti or suppression of toxoplasmosis. Nocardia and Listeria as well are inhibited by Bactrim, and so we use it. It also might help with post-transplant UTIs. So that's generally the go-to. Now, if somebody has a sulfa allergy, we're using the other typical options, right? Hep C might be a little bit of a longer conversation. Let's do Hep B and HIV real quick. Hep B, we generally would have effective treatments for. Lamivudine is an older one. I'm blanking. Entecavir is the more effective drug that you'll see more commonly. And we usually treat that pre-transplant. Now, patients can develop Hep B reactivation. And so we, as a routine, check recipients for presence or prior Hep B infection. So that would be evidenced by the presence of an antibody to core, the Hep B core antigen. So if you're a recipient who has Hep B core antibody positivity, that means that you have seen Hep B virus, right? You'll have to recall, well, if you've just been immunized and you've not received Hep B virus, then you're core negative, Hep B surface antibody positive, and you're obviously antigen negative, right? So a patient who has previous Hep B exposure and now immune is Hep B core antibody positive, surface antibody positive, antigen negative, right? Okay, so if you're core positive, that means you've seen Hep B, right? And so those individuals are generally given entecavir, less commonly lamivudine post-transplant. They get PCRs checked, and then eventually their entecavir stops somewhere, 6 months down the road or so. Okay. We also do Hep B core antibody positive transplants. Guess I didn't put this on. So you can transplant a core antibody donor kidney into a Hep B. We usually say Hep B immune patients. As long as your surface antibody is protective over 10 units, international units, you can, list those patients. Similarly, you check Hep B PCRs, you treat with entecavir. Okay. All right. HIV patients is a evolving landscape. Candidates for transplantation must be non-viremic. So you have to have adequate HIV suppression in order to be a candidate for transplantation. And we used to never transplant Hep B positive donor organs. Okay, that used to be that forbidden by law. Okay, now there was a recent passage of the Hope Act, which allows for transplantation of HIV positive donors into HIV positive recipients. Okay, that can be done legally now, and our institution will do that. Okay, um, and but again, still the donor or the recipient needs to be well controlled, meaning non-viremic. And it looks like survival rates, allograft and patient survival rates seem to be similar to non-HIV infected individuals. However, this is a highly selected population. You got to keep that in mind. So they're generally going to have less comorbidities. And we generally want to take out the P450 inhibitors from their heart therapies in order to prevent some of the massive interactions with calcineurin inhibitors and mTOR inhibitors that you would expect post-transplantation. So these patients are generally taken off of the protease inhibitors, for instance, in order to make that much more simple post-transplantation. Okay?